Mr. D'Onofrio, do you and Ms. Asay have everyone you need?
Yes, we do. Thanks.
Mr. Fisher?
Yes, we do.
Okay, great. Mr. Miller, are you all set?
I'm all set.
Great, thank you. All right, we can go on the record.
We're on.
Good morning. Today's July 24th. We'll be continuing and resuming Blue Cross Blue Shield's hearing on their rates. I'll turn it to the hearing officer to call the next witness and provide any overview for the day.
Thanks, Chair Foster. The next witness is Kevin Ruggeberg. Just to give a preview of the rest of the hearing, we would next hear from Andrew Garland at Blue Cross, and then Mike Fisher, followed by any rebuttal witnesses that Blue Cross feels is necessary, followed by closings. So we have until noon to get through that. So again, want to urge folks to be efficient with the questioning. We will, I understand, need to go into a non-public session, probably with respect to Mr. Garland's testimony. So that's the plan. And with that, Mr. Ruggeberg, are you ready to go?
I am.
Okay, could you please raise your right hand so I can swear you in? Do you solemnly swear that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth, so help you God?
I do.
Go ahead, Ms. Bellavo.
Hi, good morning. Can everyone hear me okay?
Yes.
Great. Kevin, could you please state your name for the record?
My name is Kevin Ruggeberg.
And where do you work?
Lewis and Ellis.
And what's your position there?
I'm a senior consulting actuary.
Can you please turn to Exhibit 25 of the binder? Do you recognize Exhibit 25?
Just a moment. Having technical difficulties here. My pre-filed testimony, yes.
Great. Is the information in this document accurate and correct to the best of your knowledge?
Yes.
Is there any information in this document you'd like to change or clarify at this time? And do you wish to adopt this pre-filed testimony as part of your testimony today? Can you say that again? I couldn't hear you.
I'd like to adopt that as my testimony, yes.
Okay, thanks. I think there's just a little lag for me, maybe. Okay, so now the report for the 2026 individual rate filing is Exhibit 18. And for the small group rate filing is Exhibit 19. If you could please turn to those exhibits. Do you have any changes you wish to make to either report at this time?
No.
Can you explain your standard of review in these filings?
Yes. We review whether the filings are actuarially sound, which comprises three components: whether we believe the rates are adequate, not excessive, and not unfairly discriminatory.
Do you review for affordability in the filings?
We do not.
Do you review for whether the proposed rates promote quality care or access to health care?
We do not.
Do you review for whether the proposed rates protect insurer solvency?
No.
And do you review for whether the filings are unjust, unfair, inequitable, misleading, or contrary to the law?
No, although I guess I will comment that unfair, a portion of that would potentially fall under the discussion of unfairly discriminatory as defined actuarially, but not outside of that context.
Thanks. Please tell us the result of your recommended modifications to the proposed filings.
In our report, it was described as being 15.5% for individual and 7.3% for small group. My understanding from Blue Cross's pre-filed testimony is that they applied our recommendations using their full model rather than L&E's approximations, and that it was actually 15.1 and 7.4% respectively for the individual and small group markets.
Thank you. Have you reviewed the other pre-filed testimony in this proceeding?
I have.
And have you listened to the testimony today so far? Or
Yes,
yesterday?
today, yes.
Got me. Yes, you have.
Yes.
Thanks. And can you talk about Blue Cross and Blue Shield of Vermont's disagreements with your recommendations?
Yes, so their notice of disagreement listed 2 items. One, as they said yesterday, I wouldn't characterize as a disagreement, just a clarification. They noted that the hospital budgets will presumably incorporate the effects of H266, or Act 55, I believe it is now. And they wanted to clarify that we're not recommending that effect be double counted. We agree wholeheartedly, so I'm happy to clarify that we mean Act 266 as well as the components of the budget orders, which are not simply implementations of 266. The second disagreement, I'm also a little unclear on the exact nature of that disagreement. So L&E recommended an overall medical utilization trend of 4%, without recommending necessarily what the components of that be. That was based on looking at holistic measures of trend that themselves weren't really broken out necessarily by those pieces. And if Blue Cross was to be of the opinion that, for instance, the pharmaceutical and mental health needed to be 6%, and that they were to set the facility to 3.8% such that it averaged out to 4%, that would be entirely consistent with what we intended by our recommendation. So there is an interpretation of their objection that is entirely consistent with our report and isn't actually a disagreement. If they are instead saying that 4% in aggregate is itself inappropriate, then I suppose there is a disagreement, and that will probably be teased out a little bit as we move forward.
And given what you've heard so far yesterday and have read in the pre-filed testimony, is there anything you would wish to amend or add to L&E's recommendation about revising the medical utilization trend?
No.
Thank you. And is there anything you wish to add or change to your recommendations to the individual and small group filings reflected in your report?
No.
And do you said that if your recommendations as of today were implemented with Blue Cross's more precise calculation of the impact, the projected rate would be 15.1% in the individual market and 7.4% in the small group market. Is that right?
That's my understanding, yes.
Okay. And do you find those increases reasonable from an actuarial perspective?
I do.
And can you restate why you find that reasonable?
Yes, I believe that those rates are adequate for the risks that Blue Cross faces. I don't believe that they are excessive, and I don't believe that they are unfairly discriminatory.
Okay, thank you. I have no further questions at this time.
Mr. D'Onofrio, questions for Mr. Rugberg?
No questions at this time. I would like to reserve the right to follow up if anything comes up in any subsequent questioning with just a couple of, targeted recrosses, I guess. Thank you.
Mr. Becker?
I don't have any questions for this witness. Thank you.
Board Member Holmes?
Hi, just a couple of quick questions. How are you doing this morning, Kevin? Early for you.
Well, not as much as yesterday. Yesterday was early.
That's
I'm
true.
doing all right. Thank you.
Just a couple of quick questions for you, and thank you for the report and for the help that you always provide for us. My first question is just given the uncertainty of how consumers are going to react to this sunsetting of the enhanced subsidy, is there a range of reasonable EAPTC mortality adjustments?
Mortality? Do you mean morbidity?
I'm sorry, morbidity. Yes. Thank you.
Ah,
It's early in the morning still for me, I guess. Morbidity adjustments, yes.
yeah. I wish I could say mortality is going to be 0. I'm not sure that's
Yeah.
true.
Right.
So morbidity. In reality, there's a lot of unknowns here. So I am loath to give you false precision. What I will say is, so nationally, I was looking at Kaiser Family Foundation data yesterday, and the individual market is about twice the size it was in 2020. And there's a few pieces to that, including some, there's Medicaid redeterminations, there's other things, but I think a sizable chunk of that is EAPTC. Now, Vermont experienced a less radical change than that, but it's still, I think it was about 30%. I'm not remembering exactly. Again, not all of that can reasonably be attributed to EAPTC. There's CSR loads and redeterminations. But I think, potentially more than the 12% that's being assumed here is sort of a gap in what the enrollment would look like if EAPTC had never happened and the world we're in, right? The rate increases were very large and would have been experienced as much larger. So it is possible the enrollment would have fallen substantially. In fact, I think it's likely. It's kind of surprising it hasn't given the rate increases, right? And I think that's specifically the impact of EAPTC. So I'm not going to tell you that the 6.4% or whatever that's in the filing is the absolute lowest it could be, but I want to stress it is very much not the highest it could be. And a reason why these filings are so uncertain and alarming is the error bars are just so large.
Right. Okay. So in a sense, we don't have a reasonable range that we have a point estimate and there's no lower bound or upper bound. I recognize it could be higher. We don't have anything to work with as a lower bound and an upper bound. We have to, at this point, accept this point estimate.
I mean, conceptually, certainly there are lower, like 0 is a lower bound on it, right? It certainly won't cause rates to go down. I don't have a way to assign a likelihood threshold to a number between 0 and what they're using. I think what they're using is probably a reasonable median, like a 50th percentile sort of number. But it is beyond my abilities to tell you what the 10th percentile is or anything like that.
Right. Okay. And you brought up the membership changes that are potentially possible when rate increases, appear or could have appeared without these subsidies. And I'm just, we've talked a little bit yesterday about the differential between MVP and Blue Cross Blue Shield in terms of their rate increases. So do you think there might be a material impact on the size and the composition of both Blue Cross Blue Shields and MVP's proposed memberships given what we now know about the large rate differential between the two carriers?
Yes.
How would that impact the main findings in the report?
Potentially not at all. So it would potentially have some impact on admin and drive up the admin, but because so a substantial portion of the membership is still ASO and otherwise non-QHP. So it would have to be a very, very large impact to have a really material impact on the admin PMPM. Where it becomes much more important on pricing is the extent to which the morbidity level, right? The distribution by ages and disease levels and stuff like that change. However, it isn't true. So it is likely true that if there's a shift from one carrier to the other, it will generally be the healthier people shifting to that cheaper carrier. That's usually expected for two reasons, both just because people are a little bit irrational and think, oh, the more expensive one is probably better, even if that's not necessarily true. And so I'm sick, I need the better insurance. But also, if you are actively receiving care, you're more likely to have real or perceived worries about losing access to your existing providers by changing networks. So you do generally expect in a situation like this that Blue Cross will probably end up with a more concentrated high morbidity population than they do today. However, that doesn't necessarily translate to a need for higher premiums because of risk adjustment. And there is actually a world where that could theoretically translate to less need for premium. In particular, Vermont has very high premiums, which is one of the factors of the risk adjustment transfer. So I don't think I have ever seen this particular data for your state, but I have seen data in another high premium state where actually the sickest members are the most profitable because the risk adjustment sort of overfunds them. So there's sort of competing forces there where to a first approximation, if risk adjustment is working reasonably well, it doesn't necessarily necessitate any change to the premium at all.
Okay. Really helpful. Those are my questions. Thank you so much, Kevin. Appreciate it.
Thank you. Yeah.
Chair Foster?
Good morning, Kevin. Just a couple, can you explain your process for diligencing Blue Cross's estimate of the impact of H266?
Yes. We reviewed the response that they gave, which outlined their process in reasonable detail. We compared that to the estimates produced by other parties, by MVP. I don't remember exactly where, but I remember hearing estimates from, I think, the hospitals themselves. We compared those numbers to each other to make sure they were consistent with each other. But to be clear, we did not receive, data on every single drug that they dispensed and ourselves recheck that they had the right 120% of ASP at, the arithmetic of it, we trusted Blue Cross on.
How did the Blue Cross estimate align with the hospital's estimates?
I don't remember details of when I looked at that at the time. I remember looking at it and feeling reasonably good that they made sense together. Obviously, there's a limited amount that I can tie them because there's all sorts of different payers and things like that going on, and not all of it is stuff that the board reviews and that I have easy data on. I remember not having material concerns at the end of our review that they were completely out of whack.
Your opinion does not include, I'm sorry, let me ask you this. Does your opinion include a change for based on what the hospitals actually submitted in their budget request to the care board?
Numerically, it does not. Our report does say that those changes absolutely should be incorporated. And in past years, we have had that number as of hearing. That was complicated this year because of the H.266 problem. So we have been working with the board to try to make sure that we have a number in the budgets which is not inclusive of H.266. And so I think those numbers are approximately ready for, to go to the carriers and for us to work out the final rate number, but I don't have them today.
And same question for the potential exposure or reduction for mid-year adjustments. Are those reflected numerically in your opinion?
No.
And potential enforcement for fiscal year 24 overages, are those reflected numerically in your opinion?
No.
And is L&E working to provide calculations for those potential adjustments?
Yes, so I'm not sure about the last one, because I don't know that I have any actionable information on what an enforcement would likely look like, and whether or not it would be rolled into the final budget approval. Assuming it's not, and assuming it ends up separate, there would need to be a separate adjustment applied. I am not currently working on what that would look like because I don't know how it would be enforced and what magnitude it would be.
Would it be possible for you to create a range? So just looking at last year, the enforcement actions the board took, we took 0 action on Northeastern and Porter. We enforced 50% for Rutland and 100% for UVM. Could you come up with a range for the mid-year exposures and for the enforcement exposures, giving those 3 potentials?
Yes, I do want to. So I believe at least one of the enforcements was spread over multiple years. So we would have to assume that things like that aren't happening and say this is the effect, or we can give scenarios, right? But
sure,
yeah, given a scenario of what implementation would look like, I think it's fairly straightforward for us to get you numbers. So we can say, given enforcement looks like this, here is a number.
Okay, that'd be great. I'd ask you to do that. I guess using the data points of 0, 50%, and 100% would be good. And we can figure out if it's a 2-year thing or whatever. I mean, obviously, we don't know what's going to happen with any of these at this point, but having the range, I think, would be beneficial to this process.
Yes, we can provide that.
Okay. I have no other questions. Thank you. Ben, thanks for the report.
Board Member Walsh.
Thank you. Good morning, Kevin. Did Blue Cross show any modeling of what lower rates could look like, just to test how much room they had to protect consumers while staying solvent?
Yes. I'm going to struggle to remember what exhibit it is, but they did. So the board, I believe, asked what would happen to the RBC at different rating, at different levels of CTR, basically. So that is in the binder.
You don't recall it right at present?
I don't remember the numbers, no.
Okay. Were there any sensitivity analyses around, and I think this goes to Member Holmes's question. I think we're interested in any type of sensitivity analysis, confidence intervals. You mentioned error bars earlier when you were responding to her. The reason that I'm asking is that we have a single point estimate with the request, but then so much discussion about all of the uncertainty. And it just seems like that single point estimate that appears overly precise given all that's going on. So understanding where those error bars are could help us when we're trying to consider solvency and affordability.
That's a fair point. Given I already said I wanted to avoid overly precise numbers.
I know.
So trying to think of what. So this most of the uncertainty comes from a handful of places. There's the EAPTC sunset, and I would say utilization trend is the other big one. You know, one thing we said in our report is of all of the evidence that we've seen, 5% is about as high as I think you could plausibly argue is your best estimate. That doesn't mean it's the highest that could happen. There are definitely markets and stuff that have seen a 6 or 7% in a given year, right? On the low end, I am tempted to say it is plausible that we could see a 0 or 1. I'm thinking I hate to do this, but I'm thinking of a confidential thing that I can't comment on, where I'm not sure I really believe that 1% is even plausible over those 2 years at this point. And so not sure the range goes down quite that far anymore. On the EAPTC morbidity, I mean, what I will try to offer you, because I understand why you're wanting a range. Numbers that I wouldn't have been immediately very, very skeptical about on that would maybe be something like 4 to 9%, something like that. But understand that's just my gut as a person who is sort of, generally aware of the industry and these dynamics. That's not at all, I hesitate to even say that's part of my expert testimony, right? I don't think you could say it's going to have a much smaller impact than that with a very straight face.
Is there anything the board could do to make it easier for you to provide sensitivity analyses or confidence intervals?
Probably no. My objection to providing confidence intervals here is that they're always going to be based on like projecting a mathematical model onto the situation and then seeing what that model says the confidence interval is. But that is a big interpretive step that involves a bunch of judgment. And usually in these cases, if I was to put a different interpretation onto it, I would get a radically different confidence interval. And so it's some sense to actually evaluate the confidence interval necessarily requires evaluating the sort of qualitative judgments being made rather than the math. So I am able to gin up math that would spit out a confidence interval. So I don't really need more numbers to do so. My hesitation is about that range would necessarily be as much a representation of my judgment as it would be of math in some sort of abstract sense.
So I'll take a step into You mentioned that when building a mathematical model, there's judgment and interpretation. Is it wrong to say that that's also true with actuarial models?
No, I don't think that's wrong to say.
Same uncertainty and judgment needed to build the model. And if different assumptions were made, a substantially different answer might be found.
Unequivocally, yes.
Thank you. I want to ask just one more question about trend. Do you think the filing, Blue Cross Blue Shield's filing, gives the clearest possible picture of why costs are rising? And what a more detailed breakdown of utilization, like whether it's morbidity or improved access or provider behavior, would that help us help the public understand why their premiums and out-of-pocket expenses have been rising so rapidly, but Blue Cross Blue Shield is still losing money?
It might. There's a trade-off when it comes to sort of how granularly you look at data and models. And even on the level of trying to interpret it and communicate it, it's a trade-off, right? Because the farther down you get, the more likely you are to see things that aren't really patterns and aren't really there. And the temptation gets greater and greater to narrativize about them. So more information is usually good, but building, understanding off of more and more granular information eventually stops being a net positive. And unfortunately, when you're talking about Vermont, that happens faster than elsewhere because it's a relatively small state.
I believe I understand your point. With morbidity, for example, the population health changes are relatively minor over time. They're gradual, except for pandemics and natural disasters. So if we had data over time about, say, illness severity, and we had a 5-year trend looking back, and then a more recent trend following implementation of coding software, for example, if we saw if we observed a larger change than expected, we could consider whether that provider behavior or the use of that software was contributing to the change. And we could estimate an amount that it was contributing to that change. Would you agree?
I'm not sure I follow every technical line of what you said, but broadly, yes, I agree with the point that you're making.
So I ask because we're in a position where the rates keep going up, and all that we're able to tell Vermonters is that they're justified, right? And without much evidence that anybody is trying to minimize the risk or to them, or minimize the increase, sorry. And so I wonder, for a nonprofit insurer, it seems like showing your work where you're trying to minimize the rate increase would go a long way toward building public trust. And so do you see any barriers to Blue Cross Blue Shield providing that type of information in the future?
Not substantive ones, I don't think. That's
Okay.
all doable work. I mean, there's the barrier in the sense that it costs money to pay someone to do it, but those sort of analytics should generally be within their capabilities.
Thank you. That's all.
All right, I'll go back to Mr. D'Onofrio, then give Mr. Becker and then Laura Bellavo opportunity. So, Mr. D'Onofrio, any follow-on questions from that exchange?
Thanks, Mr. Barber. Nothing at this time.
Mr. Becker,
No questions, Mr. Barber.
Ms. Bellavo, anything you needed to clear up?
Not right now. Thank you.
Okay, thank you. Next witness. we
Mr.
have
Barber?
is- Oh, yep.
Can we have a short break just to turn this room over and get the next witness who is just walking into the room set up?
Sure. Why don't we take 5-6 minutes, come back here at 9:50.
9:50.
9:50, yeah, that works.
Okay.
Thanks.
Thank you.
Board Member Walsh, are you with us?
Yes, I forgot to turn my camera back on.
No worries. And Mr. Miller? Oh, I see you.
Yep, good to go.
Okay. Um, the next witness is Andrew Garland. Is that correct, Mr. D'Onofrio?
That's correct. Can you hear me okay?
Yeah, I can hear you fine.
Great. Okay.
Mr. Garland, can you please raise your right hand so I can swear you in? Do you solemnly swear that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth, so help you God?
I do.
Go ahead, Mr. D'Onofrio.
Thank you. Would you please state your full name for the record?
My name is Andrew Garland.
And what is your position at Blue Cross?
I'm the Vice President of Client Relations and External Affairs for Blue Cross Blue Shield of Vermont.
Did you submit pre-filed testimony in this proceeding?
Yes, I did.
And does that appear at Exhibit 24 in the binders?
Yes, Exhibit 24, submitted on July 11th.
Is the testimony contained in Exhibit 24 true and correct to the best of your knowledge as you sit here today?
Yes.
Are you familiar with Attachment D to the rate filing, which is Exhibit 5 in the binder?
Yes.
Does that document describe Blue Cross's programs aimed at reducing costs and making the rates affordable?
Yes.
Would you, at a high level, please describe the contents of Attachment D?
Yeah, so at a very high level, it's really a sort of a three-pronged approach. First, member-centric care management. Second, provider-focused utilization management and cost management. And third, just payment integrity and claims monitoring. Case management is about connecting members who need support, education, resources with a single point of contact that can provide comprehensive, integrative support across the whole medical, drug, and behavioral health spend, and really across every community in the state. With our partnership with Brattleboro Retreat, we launched an organization called Vermont Collaborative Care, which brings specialized sort of cross training between medical case management and behavioral case management. And together, these programs produce tremendous value for the members that engage with them. We show about 10% savings for members who are engaged in case management against those who are not engaged in case management. And that number goes up to a 16% when we have a co-occurring mental health or behavioral health substance use challenge. So 16% less spent by those members who are in case management. The provider-focused work, utilization management, right? This is about getting the right medically necessary, appropriate care for our members and making sure that what's being prescribed or performed is appropriate, right? That's both an affordability and a very important quality check. Provider cost management, the board has talked a lot about that over the last couple of days. We work hard at finding ways to lower that unit cost, and more recently to make sure that the unit cost we agree to is actually what's being executed by our trading partners. And then finally, payment integrity. I'm not an expert in this, but payment integrity and claims management is an area that we have really enhanced our work since Act 111. We've added significant resources to that team to help us be more effective at finding places where billing practices are out of line, where mistakes are happening, and maybe the provider doesn't know it. So that we've really intensified our efforts in that space.
Thank you for that testimony. I just want to check in with, is everyone able to hear everything Mr. Garland is saying? I ask only because my computer screen is glitching a little bit.
I've heard everything he said. The video is a little glitchy for me too, but.
Okay, but everyone's able to hear. Good. Thank you. And sorry for that interruption. Mr. Garland, would you please describe the process that Blue Cross uses to undertake the sorts of efforts you just described?
Yeah, so working on cost containment and affordability, it's a key success driver, right? Not only for these rates, but really for all our business. So this is a core part of what we do. We have several standing departments whose work really is all about cost containment, including our integrated health department that has the case management function that we just talked about. We have a payment integrity team. There's a reimbursement and analytics team, a provider contracting team, and I just lost my own video. Excuse me. Just one moment while I try to get it back. There we go. Yeah, so a number of departments whose functions are primarily to drive cost savings for the plan, for our clients, for our members. And then there are also cross-functional committees that bring representatives from multiple departments together, either on there's a few of those committees that are standing. They meet regularly twice a month to move this agenda forward, and then others that are stood up and sat down as needed, to complete special project work. All of those teams come to the executive team regularly to talk to us about the ideas, the performance, and the executive team helps work on the resourcing, right? To make sure that when there's a really promising opportunity to enhance portability, that we can find a way to resource those things.
And what challenges does Blue Cross face at a high level in this work?
Yeah. Well, we're constrained really, I would say, a bit by the standards of our community, right? Which are reflected in the laws that come out of the legislature, in our regulatory structure. This is a community that values a really comprehensive approach to healthcare and healthcare financing. So that limits us. There's things that are done in other states that are more aggressive, that can lower costs. Those things really just wouldn't be palatable here in Vermont.
Is that a function, for example, of laws that govern benefit design?
Yeah, exactly. That's a really great example. You think about the benefit mandates that say, this has to be covered.
Shifting to the other topic that you'll testify about today, are you familiar with Blue Cross's provider negotiations?
I am.
Could you describe your role there?
Yes, I was the director of provider contracting and then network and provider affairs for the plan for a number of years. I've worked on payment reform and contracting for MVP for a few years. In my current role, I'm the executive sponsor for our healthcare reform work that's in the payment space. And I also consult regularly with the contracting team, with the reimbursement and analytics team, as they sort of pursue, their day-to-day mission to just work on the provider contracts to create more value. I also help out with special projects. For example, I was one of the leads on the work that led to discovering and talking about the unit cost discrepancy that we found in 2022 and 2023 in UVMHN. And, we sent a letter to the board about that, but yeah.
And in that bucket of kind of special projects in this area, are you familiar with the work Blue Cross did in the recent negotiations with the UVM Health Network, coming out of what I believe the chair referred to yesterday as the May Day group efforts?
That's right. Yeah, I think because there was a strong intention to try to bring a risk deal into this thinking, I was tapped as the lead negotiator for that project.
At a high level, what was the goal of that negotiation?
Yeah, so both parties agreed right off that we had to find ways to create more affordability for Vermonters and those that we serve. The goal that I think came from that stakeholders group was to try to find a way to reduce UVMHN's revenue requirements enough that we could lower the QHP rate increase to 5% or no more than 5%, and then provide similar affordability relief for the other commercial members in Vermont who are struggling.
And that's with respect to the 2026 premiums under review, right?
Yes.
And what was the outcome of that process?
Yeah, we did not succeed in creating any new value for Vermonters. We worked on this just a little bit over a month. We were meeting 2 or 3 times a week, but we just could not reach a point of agreement that leads to anything that would impact these rates. On the other hand, the same stakeholder group that helped us kick off this project was also involved in what eventually led to Act 55, So there's still a lot of value that came out of that stakeholder work. And I really wanted to thank, the board, DFR, the legislature, the administration, so many folks involved in helping to think about that problem.
Are you prepared today to provide additional testimony and answer questions about the details of those negotiations with UVM and Shen?
Yes.
And in your view, is it appropriate to provide that information in public session?
No.
Why is that?
Well, first of all, for negotiations to work well, the video has gone out again, I apologize. For negotiations to work well, there has to be trust, right? We're talking about very difficult issues, and we need to be able to say the things that the other party doesn't want to hear or acknowledge. So if we're going to speak that candidly, I think parties need confidence that the things they say are not going to be spread publicly and potentially used against them. It's so easy to erode that trust. And then finally, I would say there's a lot of commercially competitive, sensitive information discussed in these negotiations, and it would be inappropriate, to reveal those details.
Thank you. I'm sorry to keep interrupting with technical questions, but I just lost the visual of the board members and Mr. Garland. I see Mr. Becker and Mr. Barber. I just want to make sure everyone is still here and able to hear everything that's being said.
Everything's
Yeah,
fine on our end, Mike.
Everyone's here.
Okay, thanks.
We should
And-
probably,
and sorry,
we should probably
Yeah,
check
the
with
four of you
reporter to
just-
make sure that, Mr. Lee, are you
yeah.
able to hear everything all right?
Yes, I can hear everything.
Okay, thanks. So that concludes the public portion of Mr. Garland's direct testimony. And we would ask that given the competitively sensitive nature of any further information he might give on the UVM negotiations, that information be taken up in executive session.
Mr. Becker, do you have any questions for Mr. Garland about public materials?
Yes, thank you, Hearing Officer Barber. I do. Good morning, Mr. Garland. How are you?
Morning. I'm doing very, very well. How are you?
I'm okay. I don't think we've ever met. Nice to meet you.
Pleasure.
So your pre-file testimony indicates, and you already said as much this morning, that your position at Blue Cross Blue Shield of Vermont is the VP for Client Relations, and then in that role you oversee client-facing functions including sales, account management, marketing, communications, and brand management. Is that right?
Yes.
Okay, so even though you are a vice president, this is a small state. You're probably used to hearing from Blue Cross customers quite a bit. Is that fair?
That is fair.
Okay. Particularly of late, what are you hearing from Blue Cross's customers? Briefly, just, give me a little bit of what you're hearing.
Yeah, well, there's always a lot of oddball comments that come in that probably would be surprising as they don't seem to be related to most of what we do. But clearly, where there is a pattern, that pattern is around affordability. The cost of care is very high, and our members and clients are definitely feeling it across the board.
Okay. Did you read through the public comments that were submitted in these proceedings?
Yes.
Okay. And so when you read things like the comment from Melissa from Westfield when she wrote, "My family has a small business plan with the employer paying 60% of premium. It still costs us over $1,500 a month, and then we still have a $14,000 deductible." As the person in charge of marketing and brand management for Blue Cross, how does that make you feel?
Yeah, it's very upsetting. That's not what we want for our customers. The cost of care is too high. We have to find a way to break that cycle and bring it down. It is not affordable.
And when you read comments like Kayla's from Bellows Falls, who writes, since 2020, I have experience with MVP from an employer, 2 different Blue Cross Blue Shield plans from employers, trying to access insurance through Vermont Health Connect and being uninsured. The constant premium increases affect my family directly. Since having a second child, my kids are now on Dr. Dinosaur. So without having to worry about their insurance, my husband and I are planning to opt out of insurance next year solely due to cost. I cannot justify what we are expected to pay based on how little it would cover and how high the deductibles are. What would you say to Kayla?
Yeah, I would empathize. It's a terrible situation. That tragic situation that Vermonters have to even consider dropping care or coverage because they can no longer afford the cost of care.
Okay.
It's horrible.
Thank you. I'm going to pivot to another part of your pre-filed testimony. So Exhibit 24, page 3. This is in response to a question about medical cost containment programs. You say one of the things you do is provider-focused utilization management designed to ensure that services are medically necessary and delivered appropriately. Could you say a little bit more about this? How does provider-focused utilization management work, and are you able to gauge how successful these efforts are? Are there any metrics or benchmarks you follow?
Yes,
And if you,
and I should say, at the outset of answering that question, those functions do not report through me directly. They report through our CMO, who's not able to be with us today. So I will tell you what I know with certainty, and then we can follow up on those things that I'm only pretty sure about and make sure that we've got them right. So I think this one maybe is best answered initially with an anecdote. Before OneCare was launched, but while it was being talked about, I did a tour of independent primary care practices around the state just to talk to them about what it's like to work with payers and how they're thinking about an ACO. And one of the things that surprised me in that tour is several primary care physicians at different practices in the conversation about prior approval said, you know, prior approval is kind of useful to us sometimes because, you know, a member will come in with really complex orthopedic type injury, right? A joint thing. And we know that there's some imaging that we need to do right away to figure out where to go next. We're not experts at that. We don't have those people in our practice. So the PA helps us figure out what the right service is in that, you know, what the right test is in that situation. And I think that bit of feedback from those providers, to me, tells us like what PA is, you know, when it's at its best and sort of perfectly implemented. It's really a decision support tool to make sure that what we're paying for, and this is a cost and quality, right, concern, and what we're paying for and the medicine that, you know, we're enabling as the financing partner is really what that member needs and is appropriate medically necessary care.
okay.
I don't have by the numbers, but I can tell you that when we look internally on our cost management work teams, and that's not pricing numbers, tends to be the biggest cost saver of all of our programs.
Okay, so it's fair you don't have the numbers on you. It would be, I mean, I'm not, this is weird for me. I'm not, you know, on the board in a position to ask for follow-up information, but I mean, I think I'd be interested to see what the savings are from these utilization management programs. So maybe in a future filing or something. My next question, you testified just earlier that Blue Cross has intensified our longstanding efforts around payment integrity and claims monitoring. And it's just that word intensified. So it makes me think, shouldn't Blue Cross always be sort of at maximum intensity with these efforts?
Yeah, well, that's a that's sort of I think there's a business answer to that question, which is ideally we are 100% intensity on everything we do all the time, right? Every single function deserves our fully formed best, but we have a limited resources, right? We have limited resources. We have an admin budget that we have to keep as lean as possible. And we've heard the board talk a lot about that in the last day or two. So, we do shift our focus around, right? We establish priorities. What are the most important problems in front of us right now? Right. So if we go back a few years, we were investing in programming to help pick up some of what was lost as the ACO moved away. Then we started to notice the claim surge, and we thought, hey, we really better double down right now on claims monitoring and payment integrity, even though the legislature just passed a monstrous bill to try to slow down our work in that space. We have to backfill and make sure that that is not the cost of the claim surge, right? That there aren't some unanticipated monies just sort of leaking out from bad billing or some sort of a duplicate problem, right? We needed to be rock solid sure that one, we're doing payment integrity and claims monitoring as well as we possibly could in this environment, right? It rises up to a very high priority, but two, that it wasn't the cause of the cost surge, right? That there wasn't a technical mistake in there somewhere. So we leaned into that problem very hard. We added a number of permanent resources to that team. So for the foreseeable future, that will remain a very high priority, and we'll be working that one with a lot of intensity.
Okay, that makes sense. Claims management and payment integrity, are these parts of Blue Cross's fraud, waste, and abuse, like programs to combat fraud, waste, and abuse?
Yeah, those programs sit right next to each other. And I would say that they sort of span a spectrum from just honest mistake, technical glitch, a little bit of waste, some obvious waste, right? So there's a whole spectrum there, and much of what we find incorrect is not, motivated by bad behavior. It's just a really complicated system.
Of course. Does it say anywhere in the rate filing how much lower the rates are because of Blue Cross's programs to combat fraud, waste, and abuse?
Well, I know she's already testified, but I'm going to have to kick that question over to Martine or Ruth. Perhaps we can.
It's okay.
I
mean, I think there might be an exhibit, and it's an actuarial exhibit, so I probably should have asked Martine yesterday. I'll just move on from that. Do you know, is there an industry standard for how much fraud, waste, and abuse a well-run health insurer should be able to detect and save as a % of premium?
Well, there are numbers bandied about nationally, but I would guess, and I'm not an expert in fraud, waste, and abuse at all. I barely worked on this topic, but I would guess that every market is very distinct in this matter. I did work in a much larger market for a number of years in California and New York, and fraud, waste, and abuse were significant challenges in some parts of those markets. Don't think we have a similar environment in Vermont, but it can happen. It does happen. We have a pretty robust team in place to make sure that we're dealing with it.
So I think you said you could throw some numbers around. Are you uncomfortable doing so, or for Vermont?
Well, you've all seen them anyway. I hear a 30% number thrown around. I am a little uncomfortable with it because I haven't gotten under the hood to understand what sort of data was brought to bear to reach that conclusion. It's said in the legislature. I've heard it in the legislature many times. I don't think we're quite there in Vermont, at least in fraud, waste, and abuse. That's a pretty well-intentioned system we have.
Okay. All right. I'll move on to my last topic, which is, of course, it is the negotiations, but I have a few questions that I think I was very careful to make sure that I didn't cross the line into confidential material. So if I could just ask you a few general questions about the negotiations. The purpose of those negotiations was, if I have this right, to address Vermont's healthcare affordability crisis by, I think I'm quoting your pre-filed here, by trying to agree on a contractual arrangement that would result in the health network's 2026 revenue requirements compatible with no more than a 5% increase in Blue Cross Vermont's 2026 QHP premiums. That's what the goal was?
Yep, you got it.
Okay. And where did that goal come from? Was this a Blue Cross number? You guys came up with 5%, or where did that come from?
No. Yeah, so I think Chair Foster referred yesterday to a group of sort of senior leaders across the healthcare system, government and hospital and payer, all talking about what could be done. And I believe University of Vermont Health Network actually floated this idea that there might be some potential to work on these rates through a risk deal. And it's my understanding that the others at the table said, okay, see what you can do. You don't have a lot of time, but give it a try.
So that number 5%, though, the health network didn't suggest that, or did they? I don't know.
Unfortunately, I was not in the stakeholder meeting,
Okay,
but I don't think
okay.
they did. I agree that goal probably, I think that might have come from Stephen Gorman or one of the other folks who've been paying close attention to this challenge from that sort of business perspective.
Okay. Nevertheless, it was I'm sure we can agree, a laudable goal to achieve
Yes.
5%. Vermonters deserve that kind of relief.
Yes.
Okay. But with a 7% CTR, that would have meant actually achieving negative trend through cost or utilization or some combination, wouldn't it?
Negative trend. Again, you're asking a question that I'm probably not expert enough to answer, but I will say it was yes, it would have required a significant adjustment, a very significant adjustment. Yes.
All right. All right. Is that normal? Or have you ever approached a negotiation with someone outside of your organization providing the goalpost? Is that usual?
Yes, we have been there, never on something this big. And truthfully, this was more a phenomenon for me in New York when I worked there than in Vermont. But it's often the case that, something needs to be addressed at the community level, and we try to get those things done through contracting so that it doesn't have to be dealt with like regulatorily or through statute, right? We bring it to the hospital and say, hey, let's common sense solve this one. Yeah, but nothing of this magnitude.
Okay, we heard a lot yesterday about sort of a negotiation framework of revenue neutral, and I'm not going to bring you to the exhibit where that's at, and I won't even ask any questions about it. But you're familiar with that concept, right?
Yes.
So, being familiar with that, did this 5% goal, going into those negotiations, did it ever seem reasonable to you? Like we can really achieve this?
It seemed like a long shot. Yes.
Okay.
Especially given as, I would typically allow 4 to 6 months, maybe 9 for a negotiation of that magnitude. And we had about 5 weeks maybe to work.
Okay. All right. I think we'll have just maybe 1 or 2 more questions in the confidential session, but that's all I have for now. So thank you very much, Mr. Garland.
Thank you.
Just want to check, Mr. Knopfer, your camera's off. I assume you're still with us. Is that?
Yeah, it looks to me on my computer that it's on, so I'm here. Sorry for the technical issues on this end.
No, it's okay. I just wanted to make sure we hadn't lost
Thank you. Thanks for checking.
Chair Foster, do you have questions about public materials?
Yeah, thanks. And I think, Mr. Becker, I think the 5% target came from me, or the board, and a group of government leaders, including AHS, DFR, and the governor's office that convened those meetings. And I agree it was a difficult goal to reach, but at the same time, I think it's a long shot that Vermonters can afford a double-digit rate increase. So when we think about things that are hard, they're hard for these leaders, but these are the leaders getting paid to achieve this in our state. And I just think we have to be mindful of that. Couple questions, Mr. Garland. I really appreciate your pre-filed testimony. In the last, let's say, 5 years, has Blue Cross been successful in negotiating a rate increase with UVM less than what the board ordered in its hospital budget review?
No. And just looking at Mr. D'Onofrio to kind of cue me into confidentiality concerns, but yeah, no.
I appreciate the caution. I think at that level of generality, this is acceptable for public testimony.
So I'll try and watch it with the questions to make sure he doesn't go in something confidential. But maybe Mr. Garland, if you sense a concern, you can just pause before you answer and Mr. D'Onofrio can have an opportunity to interject. From my takeaway of some of the pre-filed, it appears that the board hospital budget process has essentially usurped the negotiating process on rate increases. Is that a fair takeaway?
Yes.
When the board issues a rate increase for a hospital, it is a cap, not a floor. And there's no possibility for the board to really understand the unique circumstances of many of the dozens or even hundreds of insurers a hospital contracts with. So the rate that we give may be appropriate for Anthem or United, but given Blue Cross's unique circumstances, that might be too high. How do you, in negotiating, take that into consideration?
Yeah, so I will say, since the board clarified that there was a cap, or that it was a cap and not a floor, we have had some minor successes with some small Vermont hospitals joining the conversation again, really for the first time since 2013. So some positive movement there. When we have a real negotiation, you said it better than I think we can usually say it, right? We bring 240,000 lives to these hospitals. We bring an unbelievable level of service. I doubt that there are many plans in the country that even come close to the sort of care and feeding that we provide to all stakeholders that we interact with. And we use those facts to let the hospital know what we think the right answer is for Blue Cross Blue Shield of Vermont. And that, to your very good point, it's not the same answer as the answer for Anthem or United or Aetna or even Cigna and MVP, who I would respectfully say are significantly smaller and create, therefore, significantly less value for Vermont and Vermonters and the hospitals that we're talking to. We pushed very hard on those points, and that approach was extremely successful up until the board process came into play, with the Single Payer Act.
So I really appreciate your candor and your direct and your, I guess, cross from Mr. Becker about, you called it a tragic situation, untenable, unaffordable. I completely agree with those assessments. And you said that we have to break the cycle. Tell me how we do that.
Well, I think it's this revenue neutral term that we've been throwing around I think it's a place that we have to focus. I'm not sure I can fully answer that question without offering some examples of what we're talking about there. And those would be very provider specific, and I think probably inappropriate to discuss publicly. But I will say more generally, we must rebase the spend as we accomplish savings. If we don't rebase the spend as we accomplish savings, then the savings are momentary, right? They land in our lap for a few months and then are immediately gobbled up again by a system that says, well, those savings don't matter. Let's remember how much we were making before the savings. We need that plus more. Right. So that's the logic of most of our healthcare system right now, or much of it on the provider side. That's really difficult to deal with. we have to accept the possibility that the healthcare system can be more affordable, which means we're gonna make less money as a hospital, right? But our mission is not to make as much money as possible. Our mission is to provide care. So if we're providing that care, we can make less money and still be very successful, right? So to me, that's the turn that we have to make. There's no possibility of any massive payer cost management programs overwhelming or slowing down this particular revenue model. It's self-healing.
Totally agree. The system's not sustainable as currently structured, in my view, and outside experts' view. And my question to you is, where should Blue Cross be focusing its rate increases from the perspective of quality, access, affordability, and population health? And my question is kind of getting at, historically, the differential between what community providers received in Blue Cross rate increases and what the hospitals received was dramatic. And I think through a lot of good effort by a lot of people, that has become a much more level playing field. I think in even some instances, some of the community providers are getting slightly higher increases. And so my question to you is, as somebody who negotiates and looks at these rates and thinks about them, two-part, considering quality, access, affordability, and population health, what types of providers should we be looking to use our limited resources on, or focus our limited resources? That's the first part, and then I'll follow up.
I would say that the answer to that question is any provider who is willing to engage in the problem. Honestly, I really don't care. I doubt anybody at the plan does how they come to us. So you're the most expensive provider on the planet, but you're here to help. Let's talk, right? So engagement is really the key there. And I think, across those dimensions that you mentioned, affordability, access, population, right? We don't really have the luxury of ignoring any of those. We, sometimes by law, by regulation, by accreditation, we really have to respect every one of those dimensions with everything that we do. But we can acknowledge that some providers can really help with quality, but they may not be able to help as much with affordability or population health. So let's get as much we can working with them in the quality space, right? And we develop sort of a portfolio approach, I guess you would say.
And same question as to specific hospitals. Are there specific hospitals that, from your viewpoint, the board should be considering investing and allocating rate for purposes of improving quality, access, and affordability in pop health?
Yes.
Which are they?
Well, there are not many. I'm going to be honest, but I think the criteria is the same, really. So I think I mentioned that 4 hospitals listened to what the board said about our commercial rate allowance. It's not a floor, it's cap. 4 hospitals listened to that. That says something to us, I think, right? Other hospitals are ignoring that guidance, or in some cases, even trying to contravene it. That says something to us too. Like you, I read, I think you were alluding to this earlier, the Oliver Wyman study. Was it Oliver Wyman? I'm forgetting my studies. The Bruce Hammery study, with just great interest. I've read that study about 15 times now. I think there is a tremendous amount of wisdom and opportunity given to us, but the answer is never the wisdom or the opportunity. It's the engagement and the execution, right? We have to work on the problem if we're going to advance the solution, and we have to be honest about that, right? We can't come to the table and say we're working on the problem, but really have our own set of goals, our own agenda that are not related to solving the problem. So I think I'm really not comfortable naming names, as you can probably see, but I think I would develop a set of criteria if I were at the board that sort of asked those questions about what does real engagement with these solutions look like, or with these problems look like, and who's really engaged, and who's just pretending to be engaged.
Yeah, no, I appreciate that. And my experience in the May Day group meetings was that there was a lot of engagement and effort and no success. And that's not acceptable to the state. It's just not. So I do think that from the board's perspective, having the insights as to who is engaging would be valuable. I won't have you do it in a public setting, but if there's a confidential way you can do it or something, I think that we do need to know that information, and we need to make sure people are not just engaging, but succeeding. And we need to kind of concentrate on that, because if people don't want to engage, they're not going to be part of this. It's not going to work. In terms of the negotiations, I appreciate the dynamics about the market dynamics, the leverage negotiations, and all of that. What needs to change so that that is not a barrier to Blue Cross being able to meaningfully and fairly, in good faith, negotiate?
Yeah, that is a really hard question.
We're going to have to
because
find an answer to it.
I have considered it and wondered, if the board commercial rate mechanism just stopped tomorrow, would this dynamic change and shift back to where it was? And I'm not entirely convinced that it would. So I hate to give you answers that are so high and not very useful, but I think this problem starts with governance personally, right? To me, a lot of the challenges that we have in the healthcare delivery system, and this can happen on the payer side too, right? They stem from the fact that the goals, the mission, the orientation, the culture of the organization isn't aligned with what the community needs, right? We're maybe creating value, but we're not creating the value that the community needs. And to me, that's a governance sort of board level question. What's happening at your organization that you're working so hard, collecting all this money, spending all this money, but you're not actually making things better for the people that you serve, right? Broadly speaking, you're not accomplishing your whole mission. That inability to negotiate, or that unwillingness to negotiate, to even talk about negotiation, right? In some cases, don't even bring it up, right? We've gotten that response. That, to me, that is rooted in that lack of clarity about why we're here and what we're doing, right? If you can't sit down with a health plan who's represents almost a third of Vermonters, and maybe a little more than a third, and talk realistically about what's going on with the cost picture at your hospital, then you're not aligned with your mission. You're not aligned with you. There's no possible way, right? You're focused on the right things.
There's a lot of conflict between an individual entity's goals and what the state's goals are. So that's something that we've been working pretty hard on, is getting pull through, realigning executive compensation with the legislative leadership that we had on that, those types of things. I think there's more to do, and I'm glad that you're mindful of that, because I think it applies to all actors, including regulators and everyone else. If the board process has essentially usurped the negotiating process for Blue Cross with Vermont hospitals, how does Blue Cross consider access, quality, and affordability in awarding or negotiating rates?
Well, as I outlined, I think in some detail in my pre-file testimony, with the hospitals and with some practices, not many, but with some professional practices, independent practices, there's not a lot of room for us to stick to our ground. We have received termination threats, and we've seriously considered what it would mean for that community, for this health plan, for all those members, for the clients, if that termination were to happen. And the calculus pretty much always shows that it's a lose-lose-lose situation, right? A loss for the plan, a loss for the practice, and a loss for the members and clients. There's just no there's no win there. We have no meaningful redundancy in our network, meaning essentially we need every single provider that we have to provide sort of bare bones access, right? Access by the numbers. When in reality, even with a network that includes, I think, 97-98% of Vermont physicians, we don't have enough access. So this is really a tough challenge.
So is it fair to say in Blue Cross's negotiations with Vermont hospitals, you've not adjusted the rate increase based on quality?
No, we don't have, we have in the long past had those quality incentives in some hospital contracts, but not currently. And we had hoped that the ACO construct would have allowed us to sort of revitalize some of the contracting work in the hospital space, but that did not come to pass.
So if a hospital has declining quality or even significantly declining quality, that wouldn't impact the rate that Blue Cross is able to negotiate with them.
No, other than that, we have negotiated in some provisions that allow us to not pay for certain just awful, right, outcomes. We can step back from those, and yeah, but that's about it.
And same question for access. If a hospital is very low provider productivity, very difficult, bad access, has that influenced the outcome of the rate negotiations at all?
Yes, that has. I'd like not to go into too much detail about that publicly, other than to say that yes. And we do have in some communities a little more overlap of some professional practice so that we can at least invoke the possibility of you not being in our network anymore as a real threat to get providers to the table and to talk about those factors that you're discussing.
How many hospitals in Vermont could you not have in your network and maintain network adequacy?
I think the answer is 0 to 1. There is a possibility that there's one hospital that perhaps we could cover, but given the challenge of accessing care, I think that would be unwise to let that hospital leave the network.
Yeah, I'm not suggesting in any way with these questions that you should. I just want to understand the dynamics. And what I'm taking away is that this barrier is a real challenge when it comes to negotiating, because you explained how the math ultimately works out.
Right.
What about the cost of care in negotiating with Vermont hospitals? Are you at Blue Cross able to negotiate lower rate increases due to the cost of care at a particular hospital?
We've had some success with that in the past, sort of before the 2014 shift in dynamics. That was a major driver of negotiation, right? So as we had talked about before, we talked about the size, the purchasing power, the local non-for-profit nature of Vermont, but also let's talk about this orthopedic panel. Seems like you're spending 3 times as much as anybody else on this service. What's going on? So yeah, we've brought that sort of cost concern into the negotiation, and most recently, those 4 small moves that we got in 23, and there was one in 24. I believe every one of those is related to a specific cost concern that we raised and said, hey, there's a problem here. Can you help us? Can you help us start to move it in a better direction?
And those examples that you're discussing, were they counterbalanced by increasing rate in some other area? I guess what I'm getting at is, like, did you actually net out below the Green Mountain Care Board's rate increase?
Yes, we did for those. Yes, that concept of sort of revenue neutrality, or that doesn't exist with every trading partner. That's pretty localized, in fact.
Okay. I want to talk about what I'll call disparate rate allocation. And by that, I mean, there's a whole number of services and there's a charge master. And my understanding is on some charges in your negotiation, they'll go up well above what the care board ordered as a rate cap. And then some it will go below. And then there's some math that says it weights out to whatever the care board had ordered. With regard to, I'm going to pick on UVM because they've been over budget a couple years in a row here. Can you describe what services have had the disparate rate allocation above what the care board had ordered? Like just sort of the big 2 or 3 that are going up the most.
Yeah, I'm not sure I have that data handy. I can offer a couple of examples, but maybe before the examples, I think I'm not sure that there's a broad pattern. We see the problem most distinctly in outpatient. So maybe that's the answer that you're looking for. Within outpatient, is it drugs? Is it lab? Is it procedural? I think it's kind of popcorn, right? Some up, some down, some right at the rate cap. So it's a bit of a mix. We have seen, so one example would be there was a screw, I think this was at UVMHN, that had almost no volume in the study period. It ended up getting a significant rate increase, that particular code, but it had no volume in the study period, or very little volume, so it really didn't affect the answer. And then in the performance period, it had tremendous volume. It was being used a ton that year. So in practice, it affected the answer a lot. On paper, it didn't affect the answer at all.
I would ask as a follow-up that in the last, I guess, 3 to 5 years, I mean, I'd love 5 years. If it's very onerous, I'll take 3. Of the top 5 to 10 services that had the largest increase in each of those years, and then also an overlay of what the corresponding volume increases were. Because my concern here is that this can really dramatically spike healthcare costs. If you're having, and I don't think the insurer is in a very good position to foresee where these volume increases are going to occur. The hospital knows that we're going to hire 3 more doctors, or we're going to get a new MRI machine, or whatever it might be. So your study period and your weighting averages in that seems like a very, very ineffective way to control this. You're just at a massive informational disadvantage in that negotiation. Is there, and actually, as I look at hospital budgets, I'm seeing some really big spikes in MRI and CT. It's a massive margin maker, and I want to know what kind of rate has been allocated to this area that's really spiking. Generally, some hospitals are pretty flat in inpatient, but MRI and CT can be up significantly, and that's going to blow our healthcare costs through the roof, and your members will be the ones footing the bill. And I have a real problem with that. And if that's something the board needs to address in our regulatory process, please help us understand it to do so. Actually, on that note, is there anything that Blue Cross would suggest that the board should consider doing to protect against that kind of outcome?
Well, I think the most important thing, particularly with those MRI CT services, which I personally consider to be sort of the commodity end of what we do in medical care, I think the board working on reference-based pricing is probably the most important action that you all can take. And I'm glad you mentioned those. I was sort of itching to jump in when you were talking, but you didn't ask me a question. MRI and CT, there's no value created when we charge 500 or 600% of Medicare for these services, right? It's all we're doing is marking up, just taking money from the consumer and moving it to the provider. That's really obnoxious, right? When pricing is out of line with value, it's wasteful. So those services, a lot of commodity services, labs, MRI, CT, other imaging, I think those are really important to examine and ask, why we would ever need to charge 3 or 4 times cost for these services when they don't generate any value. So I think pursuing reference-based pricing is tremendously important. I think the other thing that the board could potentially do, and I'm not prepared to give you sort of details on this, but there are some places where minor regulation could be extremely helpful in dealing with difficult reimbursement problems when the provider simply won't negotiate. Just some really mechanical stuff, I think the board could order that would solve or take the pressure off a number of problems. And I think we can detail out some of those for you. I'll just offer you one quick example. We reimburse some inpatient care on a DRG, which is Medicare's methodology. And Medicare allows for outlier claims, claims that will cost way less than charges or way more than charges. So the sort of averaging mechanism of DRG should work. We have some real problems with outliers with some facilities. They need to be fixed, but we cannot negotiate the fix. The provider simply refuses. I think there's a technical fix there. There's a way in which outliers should be handled. It's a math problem. The board could order that, and that could just help us break an impasse that we've been stuck on for 15 years.
Yeah, and follow up, please send in those suggestions. We're very open-minded to whatever we need to do and work with all the stakeholders, including the hospitals, on this. In terms of the disparate rate allocation, what would be Blue Cross's position if the board were to evaluate prohibiting that practice?
So prohibiting, so we would no longer.
Let me give you a
know-
hypothetical. The
Yeah,
board
thanks.
orders a 3% rate increase, and the board orders Blue Cross and or the hospitals, both either, that cap is a cap on any service that's provided. You can negotiate below it, so you can have disparate rates below it, but no service can go over it. What would be Blue Cross's position on that?
I'd have to check with our reimbursement director, but I think that works, honestly. I know that team has been sitting with some of the hospitals trying to hammer out a methodology to get kind of to what you're talking about, but I think what you just proposed would kind of solve the problem instantly.
Well, it sounds to me like you're, as a cost containment tool, that's an area where there's risk for your members, that the rates are allocated and then the screw all of a sudden is the most popular thing anyone's ever heard of.
Right.
All right. Similar question. The board, we obviously operate at a very high level for every hospital and every, it's a high level regulatory structure, and necessarily, like we're not in everyone's kitchen. As much as sometimes they may feel like it, we're really not. In our board process, we have an NPR cap, and that protects the total cost for Medicare, Medicaid, and commercial, but it doesn't protect an individual insurer. And in your circumstance, Blue Cross's finances are beyond strained, and you're asking for very significant member costs to deal with that. What if there were a cap on the total commercial spend that Blue Cross could pay out in individual contracts, like an NPR for Blue Cross?
Yeah, I think that would be extremely helpful. We have certainly had before the board started really leaning into enforcement on net patient revenue. We had conversations with hospitals where we said, hey, you blew way past that net patient revenue cap. We need some money back. And the response was the predictable, well, it wasn't with you guys. That all went, that was United and Cigna, not Blue Cross. So you don't have anything coming to you. So at a minimum, it would solve that problem, right? Making it very clear to us exactly what our risk is in each of these provider contracts. And I think it would also have the benefit of pushing some of that engagement that we talked about earlier. Now, if you know exactly where the line is and you know that you can't go past it, you may have to pay a little more attention to how you're managing utilization at your facility.
Well, right. I mean, a goal of state healthcare reform, for as long as I'm aware of it, is to reduce spending in hospitals and move it upstream to more preventative care. So
Yes.
I don't see that happening when I look at the data that we see from year to year. Would having that total cost of care cap for an individual payer such as Blue Cross, in your opinion, would that, I'm thinking about the principles of healthcare reform 9371, having that cap, would that be consistent with the principle of healthcare reform of containing all system costs?
It seems like it would, yes.
Another principle of healthcare reform is reducing administrative costs by reducing costs that do not contribute to efficient, high-quality health services or improve health outcomes. That, to me, kind of gets at some marketing expenses, administrative costs, managers on top of managers, external relations, all of those types of things that don't immediately impact care. Now, some of those obviously have a tangential relationship, and they can be on a spectrum from stronger to weaker, depending on what it is. How do you at Blue Cross evaluate a hospital's rate request in light of their operations. And by that, I'm getting at their administrative costs and potentially costs that don't contribute to an efficient, high quality system.
Yeah, I don't do that work directly. I think that happens with our reimbursement and analytics department and our contracting department. And I will ask them as a follow-up if they've accomplished more in that space. Truthfully, I haven't heard too much about it. The Hammery report certainly gave us a lot of information, and some members of the board may recall that a few years ago when I testified, I asked for more templates and more standardization of hospital budgets to help us get at that problem. And truthfully, I don't know that we've made a lot of success. I will say that when we started to notice the cost surge, we did ask ourselves some questions about the administrative overhead of some of the larger institutions that we work with, and whether this was potentially contributing to the problem. Since then, we have the Hammery report, which suggested that it really is. But understanding a hospital's administrative budget is a really sophisticated exercise, as the board knows better than I do. So templatizing or summarizing that information in a way that we can dig into it and use it. And again, the use would primarily be a negotiation, right? So probably not a world mover initially, but I think it could be a powerful force.
Yes, I mean, as I read the law and just looking at the expenses and these healthcare costs, I do not think it's appropriate for your ratepayers to be paying for unnecessary expenditures. And I don't think that they should be, I don't think your rate should include that. I think that Blue Cross should look at some of the, maybe, I know it's not easy, but there's discussion that can be had. There can be explanation required for certain costs going up. I'm looking at some hospital budgets this week. There's a number of expenses that are going up that I have a difficulty understanding. I think that Blue Cross has an obligation to its organization, given your financial position, and its members, given the cost of the members, to really go another layer deeper in your negotiations and look at the statute and understand that Blue Cross should not be paying for some of these things if it finds that they're inappropriate. So I just wanted to say that and point you to the statutes that provide you that authority to do that. And I asked Ms. Grisholm Lemieux about it yesterday. Okay, I have no questions, other questions. I really appreciate your candid and very thoughtful testimony.
Thank you. It's a pleasure.
Board Member Holmes?
Yeah, thank you, Mr. Barber. And after that, all of those questions, I mean, many of my questions were actually answered in that testimony. I think Chair Foster hit on a lot of the important topics, and I really also appreciated your candor and helping us better understand the challenges that you face, and frankly, your recognition of the challenges that Vermont faces right now with affordability. We do need deeper engagement, and I appreciate your call for that. I'm actually going to just dig into a few questions that I had that weren't touched on already. And it relates to, we haven't talked, although Chair Foster did bring this up about quality, we haven't really touched on quality much yesterday, and it is absolutely so important. Have you, I guess, let me ask you this, how does Blue Cross Blue Shield measure the quality of care?
Well, we use a number of just industry standard metrics, right, which give us a pretty good look at the most important sort of indicators of quality. There are many more quality metrics available than I think most payers have access to or use readily, right? It's very expensive and to produce that data. And what really becomes challenging, even for us, is that numbers get very, very small when we start to look at like specialty quality or even some of the hospital quality metrics. So some aggregation there might be helpful to us. But generally, we're looking at that set of metrics that NCQA, asks us to look at each year. And that's primarily how we sort of view access. We have pretty stringent credentialing requirements that help with quite a lot at the front end. And then we have an investigative team It's very small, but one that does follow up on incident reports. If a member calls and says, you know, I went to the doctor's today and something really weird happened, you know, we investigate those things so that we can get to the root cause of, you know, what went wrong here and how can we make a excuse me, a systemic improvement.
So one of the areas that I noticed was you have these blue distinction centers and blue
Yes.
distinction centers plus, where you
Yep.
provide for your members an assessment of facilities for quality and safety. I guess those are the blue distinction centers. And then the plus, you get an extra bonus if you're efficient and cost effective.
Yes.
Are those reliable for Vermonters to your members to use to direct
Yes.
their care?
They are. Unfortunately, there were volume requirement there too for that recognition. So I think there may be some panels in Vermont that would be blue distinction or blue distinction plus, but we simply don't have enough cases, you know, for the data to be credible. But where we have published that an organization is a blue distinction or blue distinction plus center, yeah, that's a lot of data. And a lot of third-party analysis, right? That the association does that work. I'm very
Does that work
confident
for
in the
you?
results.
Yeah.
Yeah,
So, because I was struck by, frankly, the lack of Vermont providers on that list. I don't actually think there was a single blue distinction plus center listed for any of the services that Blue Cross Blue Shield captures data on. So, and frankly, there were very few blue distinction centers. So I would love to understand, is it a volume issue or is it
It
a
is.
quality issue?
well, the lack of blue distinction centers is a volume issue. The lack of blue distinction plus centers is an affordability or cost issue, right? Most of our hospitals are very, very expensive. There are one or two that are inexpensive enough. I think that if they leaned into this, they probably could have a blue distinction plus certification for some of their services. But most hospitals aren't close to that in Vermont.
Okay. The volume issue is a bit concerning too, just simply because there were some hospitals that I would have expected to be on the blue distinction list for services such as maternity care, where you would assume that there is enough volume to be on the list. Knee replacements, where you would assume that there's enough volume to be on the list. So if it's, and I don't want to spend too much time on this, but it would be really helpful if it's possible to get access to the calculations and the data that's behind it for us to understand, yes, there was enough volume here, but the quality didn't measure up versus this is just a small sample size issue. And we can't, verify whether the quality here is adequate or not, because I was really struck by that. And frankly, concerned. Have you noticed any changes in quality as your ability to tie contracted rates to quality outcomes has decreased?
I don't think so. Our quality team is still working really hard. You noticed I think in Exhibit D, we talked a little bit about VBIC and ECPC, two programs that we have that are really trying to work with those providers who are engaged or thinking about getting engaged. And that's a really resourceful, clever, hardworking team. So they push pretty hard on those metrics. And I would say that too, we talked about this, I think it's important meetings, all the time and energy and money that went into OneCare, it never really materialized as quality gains that were consistent and sustainable. So there was no fall off really from that going away because we really hadn't accomplished much.
I mean, you've shared a lot with us, not only in the binder, in the confidential materials, you've been very candid here. There are clear price differences across hospitals. There are very clear, probably, quality differences across providers. I feel privy to that information as a board member. I'm concerned that consumers and members don't have access to that same information. And I know that you have an app. I know that you have a website that has that information, but those are passive, it requires a
Yes.
member to access the app. It requires a member to go on the website and do this due diligence. And frankly, it takes a little time to find all the materials and find these blue distinction centers or to compare prices. Are there steps that you could take, and I mean you broadly, Blue Cross Blue Shield could take to really a more active step to push
Yes.
information rather than just post information, to increase the transparency of these price and quality differences to really help your consumers, our Vermonters, better access, high quality, lower cost care. What else can Blue Cross Blue Shield do? You have the information.
Yeah, we're not quite there, but I think we're driving to it, and we're going to get there before too long. This is really a technology solution, I think. So you're absolutely right, and I've been the executive sponsor of a couple of quality transparency tools that have really been fantastic. It's amazing tools, a lot of marketing, a lot of market launch. Let's use this tool with very, very limited success. So it's clear that the idea that the consumer is just going to go looking, that's not going to work. Many have tried. I think all have failed. What we need to do as a system, and this is not just the Blue Cross challenge, I think others need to rise to the same problem. We have to be paying attention in real time and serve up the information in real time. So you have that MRI of the knee, right? Or you have that first visit with the orthopedist, and we get the coding back that you're being diagnosed for a knee problem. We should be reaching out to you at that moment with a text message or an email that says, hey, saw that you're dealing with some knee problems and an MRI has been ordered. Did you know there's 4 MRI, things in your county, and here's the relative cost and quality, right? So we have to bring that information really close to the transaction so that the consumer can take it when they need it. We put too much, I think, on them to expect that with everything else they're dealing with when they have a medical problem, they're going to think, wait, does Blue Cross have something, right? Even though I've sent them a letter, I sent them a brochure, it's got to be at the moment. And that, technology is going to help us get there.
Yeah, and I can appreciate that. But we don't have that kind of time. I'll be honest with you. We need to, we're facing an affordability issue now. So let me ask you, as VP of External Relations, would it be effective to put ads in the paper with, differences in prices for some of these really high frequency, imaging and things like that in local papers? Would it be effective you talked about governance. Would it be effective to talk more directly to legislators about, the cost and the quality of the care in their communities and put pressure on, board members? What else in terms of external relations could you do, could your, colleagues do to really inform the public right now in real time?
Yeah.
Through other vehicles?
I love this question. So you may know that that we built a number of information sheets. Excuse me, I don't know why I'm losing my voice. A number of information sheets for the legislature this year. And one of them was exactly on this topic, and it was extremely impactful. The dialogue that was created, and ultimately, I think the passage of Act 55, really the sharing that information was a key force in bringing that change about. Not the only force, but I do think it was a very important one. And we will absolutely continue that dialogue with the legislature next year. We are starting soon, within weeks, a social media campaign to take some of that information and make it available to just everyday Vermonters on their Facebook page or their Instagram page, just so they can get sort of little bite-sized looks at what's happening here. I'm really excited about this. It's the first time we've tried something like this. The newspaper article idea is tantalizing. I'm going to give that some thought. Probably be a reaction, which can siphon off resources and attention. And There's some things to think about there, but if the board is supportive, I'll think on that one. Because we do have to get the word out.
We're in an affordability crisis and people need to be armed with information to basically make lower cost choices. That's the reality. And so I would, I think information is power. So I think, I do have some more questions, but they're probably for confidential. So I think I'll pass it on to my other colleagues, but thank you so much. I appreciate it.
Thank you.
Board Member Walsh, before you started, we got 54 minutes. So if we're gonna, this has been a great conversation. I don't want to cut anything short, but if we're gonna do a non-public session, there's not a ton of time to also hear from Mike Fisher and do closing. So just be mindful of time.
Thank you. I have been there have been some great questions by my colleagues. And I don't have much to ask, but I did want to follow up with one question after thanking Mr. Garland for being here. And it's a follow-up to something Mr. Becker raised. You noted a family with a $1,000 a month payment for the premiums and a $14,000 deductible. I'm wondering if wouldn't it be more affordable for that family if they've been healthy to forego coverage?
Well, it may be. I don't think I would ever advise anybody, much over the age of 20, to take that path.
I understand.
Yeah, sure. I mean, sure, it will be more affordable in the short term. Yeah.
And that family making that decision, because it would be very likely would be more affordable to them. The chances of getting dramatically sick or having an accident are rather small. But would that be better for population health in the long term?
No, definitely not.
Would it be less
Contact
expensive?
with the
Would it be
information.
less expensive for healthcare delivery systems?
That one's over my head, but my inclination is probably not. Will probably be more expensive.
Right. And would it be aligned with our state goals? If
Definitely not.
large, no, definitely not. Do you have any sense of the number of people, broad sense of how many people in the state have $1,000 a month payments for premiums and a $14,000 deductible?
I do not. I hope it's not many.
That's all. Thank you.
Thank you.
Mr. D'Onofrio, any redirect?
No, thank you, Mr. Barber.
Okay, I heard at least one board member say they have questions about some of the confidential material, so would suggest that the board move into a non-public session to do that questioning. As I said yesterday, there's a provision in the rate review law that allows the board to discuss confidential information outside of a public hearing or meeting. So that would be how we would do that. Would any board member like to make that motion?
I can. Mr. Barber, do you want to do Mr. Fisher first so we wrap up the witnesses before, or do you want to just go with confidential session now?
I'd like to just do the confidential session now and come back and hear from Mr. Fisher.
Okay. I move that the board go to a confidential session to hear information pertaining to contract negotiations between insurers, Blue Cross, and hospitals and providers.
Second.
All in favor, say aye.
Aye.
Aye. Motion's approved, and we'll move to confidential session. Thank you.
Do you want to run to the bathroom?
It is all right.
Okay. Can you hear me?
Yes.
Okay, so we're ready to proceed on this end.
Mr. Lee, are you ready to proceed?
And Mr. Barber, do you need to note for the record that Mr. Garland's testimony is now concluded? He's here if you need him for anything further.
I think the record should be clear.
Okay,
Ready to move on to Mr. Fisher as soon as I hear that court reporter is with us.
okay.
Turn Officer Barber, Charles Becker is stuck in the waiting room for this meeting.
Huh.
Maybe I'll tell him to retry.
I don't see a waiting room.
I'm sorry, everyone. I was in yesterday's meeting. My apologies.
No worries. I think we're still waiting on the court reporter. So,
Court reporter's here.
okay, great. So then I think we're ready to go. Mr. Fisher, are you ready?
I am.
Okay, I'm going to swear you in. Do you solemnly swear that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth, so help you God?
Yes.
Mr. Becker, do you have questions or?
No, I believe Mr. Fisher just is going to speak.
Yeah, I am happy to give a brief comment. First, I want to make a brief comment about the public comments that have come in the door. The HCA takes seriously our role in advancing Vermonters' voices in proceedings like this. This year, like previous years, we reached out to Vermonters through various channels to alert them to the rate requests and the opportunities to be heard. We struggled this year, like in previous years. It's with messaging. It's important to recognize this comment period is for insurance rates. While it's obvious to everyone in this room the direct relationship between provider charges and health insurance costs, that relationship is less clear to many people who are just doing their best to make it, put food on the table, maintain their housing, get their kids to school or childcare. I think we are seeing some fatigue year after year of asking people to tell us what they think about rate increases that eclipse their incomes or their business budgets, and having those sentiments collide with the complex challenges of our healthcare financing non-system results in some frustration and maybe some disengagement. In response to some of the conversation earlier today, I'm always in favor of new approaches to engagement. We spent a lot of energy at the HCA during different times in the calendar. I guess I just want to recognize no matter how perfect the information or the packaging of that information, it's sometimes hard to get Vermonters to pay attention. Yet here we are with some strong and targeted comments this year. I'm not going to read any more excerpts this year. Charles Becker read a few earlier. Instead, just noting that these voices are key to this process and need to be noted. We should not be surprised when a Vermonter in the individual group or with a small with employer-sponsored insurance who doesn't know how they're going to pay for charges, who can't possibly contemplate an increase, expresses some frustration and some passion. To them, they're not focused on CTR or MLR or even hospital budgets. They're rightly, appropriately focused on how these rates play out in their lives. We've had an emergency or crisis, onto a new subject for a moment. In recent months, I and many others have talked about the crisis or urgency in front of us. I said a number of times publicly that I was very worried about how our healthcare financing system, our healthcare financing crisis would play out in this year's rate review process and hospital budgets. We expressed that urgency for a number of obvious reasons. We wanted legislative action, and we got some good legislative action. Today, we will complete the hearing. In coming weeks, memos will be submitted, and the board will make the best decision it can amongst a number of bad options. And for many of us, the sky did not fall. For some, we know the sky has fallen, and they have been priced out of the coverage and care. No matter what the details of this year's decisions, my sense of urgency and crisis is not relieved. It's only heightened. If our horizon is even only a few years out, we are not by any stretch out of the woods for this carrier, for our healthcare financing system, or for Vermonters. We have more work to do. Thank you. Happy to answer any questions if there are any.
Thank you. Mr. D'Onofrio, did you have any questions?
This is Bridget Acia. No, we do not have any questions. Thank you.
Okay, thanks. Chair Foster,
No questions. Thank you.
Board Member Holmes,
No question.
Member Walsh.
Just one question. Good morning, Mike. Thanks for being here. In your review, do you believe that Blue Cross Blue Shield has shown Vermonters that it's fighting for affordability? Or is it mostly explaining why things are getting more expensive?
I guess I want to take a little bit more time with the answer to this question than I did yesterday. It is clear that Blue Cross is taking some actions, is doing what it can, given many constraints. I think a key part of the answer is that the rates are developed with solvency in mind, and that I don't hear from the carrier a conscious attempt to reduce rates in recognition of affordability. I'm not sure if that's the answer, if that's exactly the question you were asking, but that's where my head goes.
Thank you. Thank you for being here.
Okay, thank you, Mr. Fisher. So the next thing we need to get to is closing statements. Maybe we take a couple minute break and come back and do that, which will put us just a little bit past noon. Is that a problem for anybody? Okay, let's come back here at 11:53 and we'll do the closings. Okay. I think we're all back, except I don't see Michael or Bridget. Are you, either of you with us?
I am here. Yes, thank you, Hearing Officer Barber.
And are
I do
you,
have my camera on, so I apologize if I'm not visible.
oh, there you are. Sorry. Are you, doing the closings?
Yes, I will. Thank you.
Okay. I see Mr. Lee, so whenever you're ready, go ahead.
Thank you, Hearing Officer Barber. And I want to start by thanking the board, Hearing Officer Barber, the board staff and actuaries, Mr. Fisher and the HCA and its excellent counsel, and Commissioner Sampson and his staff for all of the careful and serious work that has contributed to this process. And again, I also want to express Blue Cross's appreciation for recent efforts focused on addressing healthcare costs in Vermont. As we have heard over the past 2 days from multiple witnesses, the pace of growth in healthcare costs that Vermont has seen in recent years is not sustainable. Blue Cross Vermont remains committed to this collaborative effort to reduce those costs. This hearing often serves, as it has this year, as an opportunity for the board to explore changes and challenges in the healthcare system from many angles. That discussion is important, and I hope you've seen that Blue Cross Vermont goes above and beyond to provide information and insight to the board. But despite the breadth of that annual discussion, the core focus of the hearing is much narrower. Whether the board should approve, modify, or disapprove the rate filing, applying the rate review criteria set forth in 8 VSA section 4062, 18 VSA section 9375B6, and the board's rate review rule. I do want to pause there briefly on the legal standard because of questions raised yesterday regarding the rate review criteria. The 3 sources that I just cited, sections 4062 and 9375B6 and Rule 2, are the sources cited by the board itself year after year in its rate review orders. And consistent with those, the board issued a notice of hearing in this proceeding that says, quote, the hearing is being held pursuant to 8 VSA section 4062E1 and Board Rule 2, Section 2.307. The rate review criteria can be found at 8 VSA Section 4062A3, 18 VSA Section 9375B6, and Board Rule 2, Section 2.401. While we understand the board's attention to the overarching healthcare reform principles that are set forth in Section 9371, they are not rate review criteria, and in our view, treating them as rate review criteria specifically in this proceeding at this late date would raise some serious questions about the notice given to Blue Cross and fairness in this as an administrative proceeding. With respect to the criteria, Blue Cross has satisfied its burden of justifying this rate request. There is no serious question that the rates requested are necessary to protect Blue Cross Vermont's solvency. And protecting solvency flows through every aspect of the rate review criteria. As DFR explains, insurer solvency is the quote most important, the quote most fundamental aspect of consumer protection. For consumers to have access to health care and to quality care, Blue Cross must be able to pay its members' claims. Jeopardizing the ability to pay claims puts our members at risk, and as well as the overall healthcare system in the state. And undermining Blue Cross Vermont's solvency will not make the actual cost of healthcare any less or the cost to consumers any more affordable. With that framework in mind, I want to address some specific aspects of the rates and issues that we've discussed over the past 2 days. First, one topic and certainly set of questions has been, is a 7% CTR too high? It is not. It is, quote, necessary and critical, according to DFR, our solvency regulator. And that's because our reserves remain precariously low. There's no capacity to sustain another loss. And those losses have come in each of the past 3 years at a very significant level. And as Ms. Green testified, the 7% CTR that was approved in rates for 2025 is currently tracking only to 4% realized. And that is assuming the second half of 2025 does not go south the way it did in 2024. So the 7% request is a critical buffer against the uncertainty and risk in next year's markets. I also want to emphasize that this request does not reflect any cross-subsidization, another topic that has come up over the past couple of days. A 7% CTR is what's needed to build up the reserves that are needed to support these markets, which drive a substantial portion of Blue Cross's capital requirement because of the inherent risk in offering these plans. The cumulative loss in these markets is 83.2 million since inception, over 90 million in the last 3 years. What that means is that reserves that were built up over years in other lines of business were depleted by losses in the QHP markets. It is not reasonable or sustainable to treat the QHP markets as a one-way street using Blue Cross's reserves to pay off losses, but unavailable to make an adequate contribution to reserves, even during a period of financial crisis. The other pieces of the rate are not in serious dispute, and there's no basis in the record to dispute them. We heard from the board's actuary this morning that the rates are reasonable, adequate, and, quote, not excessive. L&E recommended only one small recommended adjustment to trend. And otherwise has fully kicked the tires on the actuarial calculations and found them reasonable. We know that over the course of the hearing, board members have been digging deep and asking questions about the calculations and how they've been done, whether they could be done differently, or whether savings have been potentially understated. And we certainly understand the real pressure to try to reduce the rates. But I just want to emphasize that the board has years of historical experience with Blue Cross Vermont's rate development, and that experience shows that the company does not pad the rates. It just doesn't. If you look at the last 3 years, the rates in these markets have been seriously underpriced. The board's actuary in his testimony today emphasized the uncertainty in these markets. The rates could be too low. And given the financial position of the company and the uncertainty in these markets, there is no basis in the record to reduce those rates. This year, more than in the past, there are some issues that remain unsettled today, even as we come to the close of the hearing. I want to address those points, and I want to start by echoing the, quote, extreme caution that Commissioner Sampson advised about any aspirational or not bankable adjustments to the rates. To be more specific about a couple of those issues, the Act 55 savings, the legislative cap on the price of certain drugs, those savings are important. We are very pleased that that law went into effect. But as you've heard from Blue Cross and from the board's actuary, the savings from that act cannot be double counted. That means that any savings attributed to Act 55 must be disentangled from the hospital budgets. There's also been discussion of hospital budget adjustments. We've only had a brief opportunity to review mid-year adjustments, and we will address them more fully in the near future. For these purposes, we just want to note that the proposals we've seen from the hospitals are explicitly limited to 2025 unit costs and would not affect 2026 prices. For those adjustments to have any impact on 2026, they would have to be implemented differently from the proposals we've seen. In closing, I want to acknowledge what has already been said in this hearing. We are very concerned about affordability for consumers and recognize the very difficult decisions that many families and businesses are facing this year, especially because of the loss of enhanced federal subsidies. Cost of healthcare in Vermont is not affordable either for individuals or the state as a whole. Those costs need to come down, and Blue Cross Vermont is a willing partner in that work. The board's discussion with Mr. Garland was productive and enlightening on those points. Specifics like caps on payer commercial spend or caps that apply for every service line can make a real difference as we move forward. What will not make a difference is reducing Blue Cross Vermont's 2026 premiums. That action will not reduce the cost of healthcare. What it will do is threaten the company's solvency and ability to serve Vermonters. For all of those reasons, we ask that the proposed rates be approved. Thank you.
Thank you, Mr. Becker.
Thank you, Hearing Officer Barber. In my opener yesterday, after laying out the magnitude of the crisis that Blue Cross is facing, when I got to the call to action part, that goal of achieving a 5% rate hike, I was afraid maybe I was being too glib. But even the chair noted, if I recall correctly, all the work groups led to 0.00% in savings. In the middle of a crisis with a clear directive to pull Blue Cross Vermont back from the brink, and hours of meetings resulted in no additional bankable savings that could help Vermonters to navigate this affordability crisis. If anyone from the public tuned in yesterday hoping to be reassured that this situation is under control, I don't know, I'm afraid they may have been disappointed. I mean, they certainly would have seen healthcare leaders being collegial with each other, even while asking difficult questions, and that's great. We should continue being kind and respectful to each other. But Vermonters are going to need more than collegiality to get through this crisis, and more, it seems like maybe they will need more than regulators and lawmakers to get them through this crisis. They need accountability at the top, not just from Blue Cross, but from the executive leadership of the other actors contributing to this crisis. And they'll need, as Mr. Garland said this morning, for the cycle of ever escalating costs to break, to accept that the care can be delivered for less money, and engagement, genuine engagement between providers and payers for how to do it. That would be the better that Vermonters deserve. Now, can Vermonters count on payers and providers to achieve it? And I will end with that. Thank you for listening, and to everyone who participated in these hearings for being collegial. It is important we don't lose that. So thank you.
Thank you, Mr. Becker. Are there any members of the public here who'd like to provide public comment? Like I mentioned at the beginning of the hearing yesterday, we have a meeting later this afternoon exclusively devoted to public comment. But if you're here and you'd like to make a comment, please just take yourself off mute and go ahead. I'm not hearing anyone, so before I turn things back over to the chair to adjourn the meeting, obviously, as in past years, we'll get a set of questions out to Blue Cross for follow-up. There's a lot of discussion of follow-up, and we've been trying to track that, but that probably won't go out until Monday. We have a little bit more time this year to deal with that, but please expect that. I'm thinking Monday. Anything we need to discuss before we close the hearing? All right, I'll turn it back over to you, Mr. Chair.
Thank you. Just really briefly, I did want to thank Hearing Officer Barber for his excellent management of this process. It's been many months, not just the last 2 days. So I'd like to thank Mr. Barber and Laura Beliveau and our rate review team, including Tara and our other counsel. We can't do it without staff. I don't think people really recognize how much work they do to get us ready. So many thanks. Second, I did want to thank counsel, very professional presentations, zealously argued on both sides, and very helpful. The witnesses were incredibly impactful. Every year, I'm amazed by how much I don't know. And when we get to these hearings, I know a lot more. Ms. Acey, I think, made a good point that a lot of this is bigger picture, but it's really critical that we have it so that we can think about solutions. And I'm glad we have this process to do it. The board's going to make whatever decision it makes. I recognize that in Blue Cross's interests and needs, that there's a strong argument that they need a significant rate increase. The board will have to balance that against all the competing interests, and the people need serious relief on these rate increases. And that's part of the statutory obligation that the board has. And a 0% rate increase has a huge risk to Blue Cross. A 23% has a big risk to Blue Cross, a 15, everything in between. So we will do our level best, and I appreciate the parties understanding that there's a lot of competing interests here. And the information you provide us and follow up is greatly appreciated. And I thank everyone for their time and the witnesses and Mr. Miller as well. So with that, I will move to adjourn.
Second.
All in favor, say aye.
Aye.
Aye. Thank you. We're adjourned.